On May 17, 2026, the World Health Organization declared the Ebola outbreak in the Democratic Republic of the Congo and Uganda a public health emergency of international concern. The driver of this crisis is the rare Bundibugyo Ebola virus, a genetically distinct strain currently surging in regions that have historically seen very few cases. The risk of international spread reached a critical point following the death of a traveler in an intensive care unit in Kampala, a city that serves as a major international flight hub. This briefing details the specific virology of the Bundibugyo strain, the technical reasons our current testing infrastructure failed to detect it, and the immediate triage protocols required at the clinical level. Because this outbreak involves a non-Zaire species, many of our existing protocols are encountering technical failures. Adapting our triage framework now is necessary to identify cases before they pass through transit points. The Bundibugyo species is genetically divergent from the Zaire strain. At the molecular level, its receptors differ enough to physically repel antibodies developed for Zaire. This genomic difference has immediate clinical consequences. While Ervebo vaccines and Ebola antibodies are effective against Zaire, they have no effect on the Bundibugyo virus, creating a total therapeutic void. There are no approved pharmaceutical options or vaccines for this pathogen. In the absence of targeted treatments, patient survival depends entirely on early supportive care, including aggressive fluid replacement and electrolyte stabilization within a strict isolation environment. The clinical stakes are high, with the current outbreak showing an observed case fatality rate of approximately 32%. Without the safety net of a vaccine or effective therapeutics, containment depends entirely on the accuracy and speed of the initial patient triage. The early response in the DRC was hampered by a technical limitation in standard field testing equipment, specifically the Ebola expert assays. These tests were calibrated for the Zaire strain. When used in Bunia to test for the Bundibugyo virus, the genetic mismatch meant the assay failed to bind to the viral RNA, returning a negative result even in highly symptomatic patients. Relying on these false negatives, medical teams treated early cases as unknown febrile illnesses, often without employing high-level personal protective equipment. This failure led to significant nosocomial amplification, as the virus was able to spread through the clinical environment before the pathogen was correctly identified. The result was the infection and death of 4 healthcare workers in the Mongwalu zone over a period of just 4 days. These fatalities demonstrate the danger of relying on legacy field assays when the circulating strain has deviated from the original test calibration. Transmission is currently tracking from the artisanal mining sectors in Mongwalu toward provincial centers and border crossings. Much of the spread is concentrated in the 20 to 39 age bracket, driven by a highly mobile mining workforce that frequently moves between informal settlements and urban hubs. We are also seeing a significant gender disparity, with females making up over 60% of cases due to their roles in caregiving and traditional community burial practices. Containment efforts faced a new geographic challenge on May 18th, when a case was confirmed in the city of Goma. Goma is currently under the control of the M23 militia, an active conflict zone that is largely inaccessible to government health teams. This insecurity creates areas of epidemiological blindness, where standard WHO contact tracing and ring surveillance strategies are technically impossible to implement. When health workers cannot reach high-risk contacts in these conflict zones, the virus is able to establish new transmission chains that remain undetected by regional authorities. The death in Kampala confirms that the Bundibugyo strain has reached transit hubs with direct global connectivity, making importation into India a realistic possibility. Your clinical screening must focus on patients presenting with sudden fever, malaise, or sore throat, combined with a 21-day travel history to the DRC or Uganda. Do not wait for late-stage hemorrhagic signs, such as internal bleeding or vomiting blood, to appear. Given the failure of current rapid tests to detect this strain, you must not wait for laboratory confirmation. If the travel history and early symptoms match, initiate strict infection prevention and control protocols immediately. Every suspected case must be reported immediately to the Integrated Disease Surveillance Program and the NCDC control room to facilitate rapid isolation. In this specific outbreak, clinicians must rely on their own triage observations rather than a negative lab result to decide when a patient requires isolation. The national lab in Kinshasa is currently conducting full genomic sequencing to determine if this 2026 lineage has acquired any new transmission factors. Longer-term solutions are in development, including an Oxford Moderna project currently testing multivalent vaccines in the UK. Until these candidates move through clinical trials, the only effective barrier to international spread is the vigilance of healthcare workers at the point of care. Check your hospital's intake protocols for returning travelers today and share your facility's readiness for a non-Zaire strain in the comments. While we wait for the final sequencing results from Kinshasa, the most effective tool for containment remains a high index of clinical suspicion for every returning traveler.